Hey all, welcome back to the Real Life Pharmacology Podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. As always, go check out the Top 200 Study Guide at reallifepharmacology.com. It is a free 31-page PDF. Simply an email will get you access to that. And then we also give you updates when we've got new podcasts and content available. Also want to remind you, as always, if you're looking for a specific medication, if you're studying, cardiovascular topics, whatever you're looking to try to learn, I've got over 300 episodes from the past on individual medications that go into a lot deeper detail. So I'm in the process here of continuing on kind of the top 200 study guide. Probably a great resource for a lot of nurses and pharmacy technicians and those newer to medications. But if you want, more detail, more in-depth things, go check out some of those individual episodes that I've got in the past that can be really, really helpful. So you can do that at reallifepharmacology.com. I got the podcast categorized. So again, all those are free and available for you to benefit from, on your drive to work, working out, wherever you like to listen to podcasts. So with that said, let's get into the podcast today. I'm on drug number 141 through 145. And first medication is Raltegravir. Brand name is Icentris. This is an integrase inhibitor that's used in the treatment of HIV infection. So a little bit about integrase, the enzyme. So mechanistically, this drug works by basically inhibiting viral DNA insertion into the host cellular genome. So a little bit more specifically, integrase is an enzyme within the HIV virus that inserts the virus's DNA into the DNA of our CD4 cells. Okay, and this is obviously a necessary and crucial step within the HIV life cycle. And if we block that step, ultimately, we can help block the action of the and replication of the virus. With this medication, there are some warnings, precautions, as always. So skin reactions can certainly happen with this medication. From an adverse effect profile, you can have some GI upset, some headache, insomnia. A few things of note that are kind of unique. So elevations in LFTs have been reported. So that's something to maybe pay attention to periodically. Rhabdomyolysis. So this is kind of one of the unique medications like statins, for example, that have been associated with myopathy, muscle soreness, elevations in creatinine kinase. So something to think about there with that medication. This medication can be used in the management of chronic HIV infection. It can also be used for post-exposure prophylaxis. This is often called PEP therapy in HIV. So with PEP therapy, it's used in combination with other agents. It's not used by itself. It's used typically with a couple examples here, emtricitabine and tenofovir. From a drug-drug interaction standpoint, antacids are really important. Polyvalent metal cations, magnesium, calcium, aluminum. These can all reduce Raltegravir concentrations. So, and if we reduce those concentrations, obviously that's going to lower the efficacy of the medication. So, really, really important that we recognize patients who are taking any type of supplements, any type of over-the-counter antacids that may have some of these things in them because it can bind up Raltegravir, reduce concentrations, and obviously make it less effective in managing HIV medications, or HIV condition, excuse me. Methotrexate, its concentrations can be increased with the use of this medication, with the use of Raltegravir, so something to pay attention to there as well. And then the other one I kind of think about, have in the back of my mind, is the use of statins with this medication. That rhabdomyolysis risk could certainly increase if we've got two medications that are potentially causing or contributing to that issue. That risk may be elevated. Next medication is Ustekinumab. Stelara is the brand name of this medication. This is a monoclonal antibody. Mechanistically, it is an IgG1 kappa monoclonal antibody that binds to interleukin 12 and 23. So those two interleukins are involved in inflammatory and immune responses. So essentially it binds to and interferes with pro-inflammatory cytokines is how this medication ultimately works. And by binding those pro-inflammatory or interfering with those pro-inflammatory cytokines, that's going to reduce inflammation. So as you can imagine, this medication is going to be used for many different types of autoimmune disorders where there's significant inflammation. So Crohn's disease, psoriatic arthritis, ulcerative colitis, these are all common examples of conditions where this medication could be helpful. It is given intravenously or subcutaneous injections. For the dosing of this medication, it's typically given in intervals that are anywhere from 4 to 12 weeks. 4 to 8 to 12 weeks are typically kind of the most common intervals. Depends upon the condition and that type of thing. Warnings with this medication. So whenever you kind of suppress the action of the immune system, it has the risk of increasing the risk of infection. So we've got to pay attention to that. If patients are getting infection after infection and their body's immune system can't fight it, we definitely need to reassess this type of medication for sure. Another thing to think about where we want an immune response is in the use of live vaccines and other vaccines, of course, as well. But in particular with live vaccines, there's a theoretical risk of that live vaccine actually causing an infection if that immune system is suppressed. So again, a couple warnings there to pay attention to. Adverse effect profile, I alluded to kind of infection. Malignancy can also be associated with that. And then we can have some injection site reactions and hypersensitivity type reactions, which is fairly common with this type of class of medications. Some considerations, generally avoid live vaccines while using this medication. I alluded to that already. And then the infection risk kind of goes along with that. Drug-drug interactions, I think of immunosuppressants that are being used, tacrolimus, cyclosporin, for example, that can have additive effects and further suppress the immune system when a medication like Stelara is being used. Live vaccines we're going to typically avoid. Again, we can have that theoretical risk of infection. And I also want to point out non-live vaccines, that efficacy can be reduced. Again, if we're kind of suppressing the action of the immune system, we may not get as robust of a response to that vaccine that we want if we're using non-live vaccines. Hey all, if you're looking for great study materials and tons more information on medications, pharmacology, or board exams, go check out meded101.com/store. We've got a great list of resources for nurses, pharmacists, pharmacy technicians, board exam materials for pharmacists, tons of testimonials. Again, go check out all those resources. Your support there greatly helps me keep producing this podcast and sharing content with all the new healthcare professionals trying to learn pharmacology or just trying to become better and refreshing their skills. So go check that out. Support the podcast. meded101.com/store. Lots of books, review courses, all sorts of good stuff there. Check out and help support the podcast. Thanks so much. All right, next medication is Meloxicam. Brand name of this medication is Mobic. It is an NSAID, so it's a non-steroidal anti-inflammatory drug. Mechanistically, it inhibits COX-1 and COX-2. And this ultimately leads to reduction in prostaglandins and can reduce, provide some pain relief as well as reduce inflammation. Most common indications, any type of pain type situations, particularly when there's an inflammatory component, So rheumatoid arthritis, for example, is a common indication there, but also shown some benefit in pain relief with regards to other types of arthritis as well, such as osteoarthritis. Most common formulation that I see utilized is the oral formulation. We've usually got a couple of doses that we use. 7.5 and 15 milligrams are probably the two most common doses I see utilized there. Some warnings with NSAIDs. You got to pay attention to renal function. It can worsen renal function, potentially lead to acute renal failure. It can increase the risk for serious cardiovascular events as well. And then obviously GI events as well, so GI bleeding, for example. And in my patient population, geriatric patients, we typically worry about this quite a bit more because oftentimes those patients already have pre-existing, insults to the GI tract or kidney or whatever the case may be. We've already got, pre-existing concerns with some of those patients, and an NSAID may contribute to that. So we've really got to be judicious in using these medications in our geriatric patient population and have to be really selective. Adverse effect profile. So GI upset's probably one of the more common ones I see there. Typically, we're going to give it with food. Some nausea and that type of thing can happen. Burning sensation in the stomach. Other adverse effects. Fluid retention's one I think of. Worsening of heart failure. That can be problematic. GI bleed issue, GI ulceration, that can be problematic. And then the nephrotoxicity. Those are ones that you're very, very likely to be tested on throughout your pharmacology, career board exams, things of that nature. So remember those. Rarely you may see some skin reactions or some hepatitis, but again, that nephrotoxicity, heart failure risk, fluid retention, GI bleed risk, those are probably going to be your most common issues with this medication. For patient considerations, make sure they pay attention for any type of GI bleeding signs in the stool, for example. So that can definitely be problematic and something for patients to look out for. Heart failure. So if you see patients with increasing doses of furosemide, for example, take a peek and make sure they're not on an NSAID like Meloxicam, which can worsen that condition as well. Rarely you may see some bumps in blood pressure. It can potentially worsen hypertension. Usually it's a dose-dependent effect, a lot like the other adverse effects where higher the dose, the more likely you may incur in that issue. Drug-drug interactions, I think, are pretty straightforward. So GI bleed risk, aspirin, anticoagulants, antiplatelets, for example. Nephrotoxicity risk, diuretics, ACE inhibitors. When we use them in combination with NSAID, that risk for nephrotoxicity can go up. Also can counteract the effects of diuretics in a sense that it may worsen edema. And that's maybe what we're trying to use a diuretic for. Other meds that can cause acute renal failure, aminoglycosides, maybe a vancomycin, using them in combination with NSAIDs may increase that risk for acute renal failure. Lithium concentrations may go up. Oral corticosteroids can be hard on the gut, so adding them on top of NSAIDs may increase the risk for GI bleed. Number 144 is Infliximab. Brand name of this medication is Remicade. Inflectra is also another one commonly used. Inflectra is actually a biosimilar medication, as this medication is a monoclonal antibody. Now, what does this monoclonal antibody do? It's specific for tumor necrosis factor alpha, or TNF alpha is the short abbreviation there. Again, it's a chimeric monoclonal antibody that binds to human tumor necrosis factor alpha, and it ultimately interferes with that endogenous TNF alpha activity. Now, if you remember, elevated TNF alpha levels have been found to be involved in tissues, fluids of patients with autoimmune type disorders. So, inflammatory type disorders, rheumatoid arthritis, psoriatic arthritis, psoriasis, Crohn's disease, ulcerative colitis. These are all kind of disorders where inflammation and pro-inflammatory cytokines are a potential issue there. So ultimately, by binding up, kind of blocking the action of that TNF-alpha, we can reduce inflammation and hopefully improve their condition. So I alluded to some of the indications, Crohn's disease, psoriasis, psoriatic arthritis, rheumatoid arthritis, ulcerative colitis are probably the most common situations I see it used for. There are some adjustments for renal impairment, so pay attention to that. I'm not going to get into the specifics there. When we kind of reduce inflammation, reduce the action of the immune system, ultimately you can have an increased risk of infection, an increased risk for cancer and malignancy, and there is boxed warnings associated with that. So again, definitely important part of your monitoring. And if you see a patient that's struggling with infection, for example, repeated infections, or they can't get over an infection, it's always good to take a look at that med list and see if they're on a medication that can suppress that immune system. Other type of adverse effects that can happen, we can have an infusion reaction, skin reactions associated with that as well. With Remicade or Infliximab, there are recommendations for how to handle an infusion reaction. So typically we're going to temporarily discontinue or decrease the infusion rate with any type of infusion-related reaction. Other things we can do, we can utilize other medications like antihistamines, for example. So diphenhydramine, can utilize acetaminophen. Corticosteroids may be utilized as well. Again, there's definitely protocols in place on how to handle these reactions, kind of within package inserts. UpToDate's got a nice resource as well there. So again, not going to go through all the details there, but recognize that we may use some alternative medications to kind of reduce the risk of infusion reaction, or reduce how severe that infusion reaction is. Now, in the case of very, very severe, life-threatening reactions, obviously we're probably not going to use this medication again. So again, needs to be kind of clinically assessed how bad that reaction was. All right, drug-drug interactions. Immunosuppressive agents obviously can have additive type effect. DMARDs can have an additive immunosuppressive type effect as well. So, azathioprine, methotrexate, any other DMARDs, these can all increase that risk for infection if we're suppressing the immune system. And then need to talk about vaccines, of course, here as well, as I did with Stelara. Infliximab, we generally want to avoid live vaccines. There's that theoretical infection risk there. And also, it can reduce the efficacy of non-live vaccines. So, important if we're looking at starting a biologic in the near future, if we can get those patients up to date on their vaccine schedules, that is ideal prior to starting the medication. All right, number 145, we've got a combo product. It is what's within many nighttime cold and flu medications. So we've got acetaminophen, dextromethorphan, doxylamine. NyQuil is a common brand name that may have this combination within it. Can't encourage you enough to go look on the back of the labels, know what each drug is doing and what it's there for, because many of these over-the-counter products vary in what's in them. So you really need to go, to the back of the box, label the bottle, and see what medications a patient is actually getting. So acetaminophen, obviously an analgesic, antipyretic type medication. Dextromethorphan is an antitussive, so it kind of reduces coughing. And then doxylamine is an antihistamine, which can have some sedative type properties, as well as kind of dry people up a little bit. Indication, obviously nighttime cold and flu, so it's going to hopefully help with some of those symptoms associated with a head cold, with flu. Relieving headache, reducing cough, may help with kind of sinusitis and sneezing and sore throat potentially. Those are primarily some of the symptoms that this combination can help with. With warnings, I would say one of the biggest things that I've seen in practice is pay attention to acetaminophen use. I see so many patients when they get a head cold, they'll take nighttime cold and flu medication, and then they'll take daytime cold and flu medication, and maybe they're already taking a scheduled acetaminophen for a pain condition. So really, really got to warn patients, educate patients that they're not getting too much acetaminophen. If we go, over that 3 gram, 4 gram max, we can potentially increase the risk for hepatotoxicity. So again, definitely something we need to pay attention to there. Adverse effect profile, I've done, I believe, each of these individual agents previously, so go look at that. I would say most people are bothered by kind of dry eyes, dry mouth, constipation, and that's probably mostly going to be from the anticholinergic doxylamine. The sedative properties from doxylamine can kind of linger into the next day as well, so drowsiness, dizziness, that can happen. Sometimes blurry vision from those dry eyes can happen as well. So again, my geriatric patient population is typically going to be most bothered probably by the doxylamine, the anticholinergic component. It can also, if you got a patient with BPH, it can also worsen urinary retention and BPH symptoms. If you got a patient with dementia, it can worsen some of those cognitive symptoms as well. So again, pay attention to it. Definitely not a benign over-the-counter type of medication, particularly if you give it to the wrong patient. Drug interactions. So acetaminophen, I think about the hepatotoxicity component, methotrexate, amiodarone, excessive alcohol intake. These are all potential additive insults to the liver, and acetaminophen can add to that, particularly when we go above recommended dosages. Dextromethorphan, the cough suppressant piece of this, does potentially have some serotonergic type activities. So MAOI inhibitors, SSRIs, these can have that potential additive serotonin type risk. I'm not terribly concerned about it. In somebody that's maybe on a low dose antidepressant for depression, for example. But if you've got a patient that's on numerous serotonergic drugs, dextromethorphan may have some additive type properties there. And then probably the other biggest thing I worry about is doxylamine and the sedative type properties with this medication, with this anticholinergic medication. So if you got a patient on benzodiazepines, opioids, that can have that additive CNS depressant and even potentially respiratory depression type additive activity. Doxylamine, again, can blunt the effects of some of the dementia medications like the acetylcholinesterase inhibitors like donepezil, so it's something I kind of watch for if I see a patient taking more than a few doses of this medication. And then I alluded to the kind of counteracting of BPH treatment. So tamsulosin, 5-alpha reductase inhibitors, it may worsen and ultimately kind of reduce the effectiveness of some of those agents with the way this drug works mechanistically. All right, well, that's going to wrap up the podcast for today. Thank you so much for listening. Please do me a huge favor, leave a rating or review on iTunes or whatever platform you're listening on. I greatly appreciate that. Share us, friends, colleagues, classmates, students, anyone who could benefit from pharmacology education. I greatly appreciate that. If you want to reach out to me, suggestions, comments, you can do that at mededucation101@gmail.com or connect with me on LinkedIn, Eric Christensen, PharmD, BCPS, BCGP. Thank you so much for listening. Take care, and I hope you have a great rest of your day.